CareCompass Network Funds Flow Methodology as approved by our board on October 13th, 2015. Anyway, so going over initially the overall deliverable required under DSRIP, the guiding principles that we used in creating the funds flow methodology, our process and who helped us along with it, and our timeline. And then we'll be moving into the actual methodology and all of the wonderful tables that go along with that, following up with some of the last two items there representing what was actually approved by the board, and as well some information on the flexibility of our budget, and a couple of outstanding items that still remain.
Just a question. Is there
yes,
a handout, is there a handout for this group?
There is not a handout for the room because it's just so large. It was sent out. It is in the PDF, so everyone at least does have it in that form. So the implementation plan deliverables, so this is the funds flow milestone to complete the funds flow budget and distribution plan and communicate with network. And so what we're at today is actually the completion of steps 7 and 8, as this is the last of 5 presentations that were scheduled to have been made on the funds flow and budget methodology. Some guiding principles that we kept in mind as we were doing this. We wanted to keep a lean, centralized infrastructure because after DSRIP, there still remains our central office, and so we didn't want to oversize that so that we were able to continue working. Looking at achieving synergies across the projects, and developing mechanisms to evaluate our reserves, working on RPU budgets, utilizing some of the folks across our PPS through the use of purchase service agreements as one way to keep our central office a little bit leaner, and several other things, CRFP, rev loss, the incentive methodology, many items that were kept in mind as we went along our process. And so, speaking about our process, so we identified our DSRIP requirements from our implementation plan. We utilized the information from the original CareCompass Network application and the implementation plan that was filed in June, using lots of guidance as provided by the Department of Health, as well as our friends from KPMG, looking at methodologies employed by other PPSs, including Flips and Leatherstocking, and several iterative reviews by the Finance Committee. And you can see on the right who helped create each project's budget. And so we've got our helpers there, which I know I've got a couple in the room with me. So our timeline, we started creating the budget actually in July. The Finance Committee was officially seated by the board in July, and we had our first meeting in August where we discussed the waterfall concept, and then during the rest of August and September we met with project leads to essentially determine a ground-up budget methodology for the project. So we essentially said, as we went through with each of the project leads, we said, all right, here's your project, here's your metrics, what is it we need to pay for to achieve, one, all of the things that we've set out to do and promised to do in our implementation plan, and two, to impact these metrics that the state has assigned to the projects. And so a few iterative reviews with each of the project leads on that, put up with some internal CCN reviews and a legal review, and then some additional reviews with the Finance Committee towards the end of September, early October, and then finally going to the Board of Directors on October 13th. It is anticipated that we will be updating this budget periodically. Based on some conversations that have been going on, it looks like our next official budget iteration will occur at the February board meeting. So we're going to be using some of the time between now and the end of January to be putting together some proposed budget changes. I'll highlight some of those proposed changes as we go through here. They generally are reflected in the actual project budgets, as some discussions have occurred at the project level and additional funding needs have come up, or different funding needs. So I'll keep you in the loop on those, because they're not reflected in here because they're not yet approved. And so why should the budget be flexible? Well, we need to be able to essentially do what I just described we're going to be doing. We need to be able to take in new information as it comes up from the project teams and new guidance that comes out from the DOH. We need to be able to act in a somewhat rapid fashion. We can't be approving an annual budget and say, well, that's it for this year. You didn't get what you wanted, you just have to wait till next year. So we're anticipating a review likely to be quarterly, at least for the first year. There's potential that it can move to a larger gap in the future as we get a better hold on some of the more specific details. Current open items, we have an open capital budget. It's $42.9 million. It's for IT. IT is a very vague, broad definition. We're waiting with our friends at Weiser Mazars to help us with our current IT needs assessment. That is anticipated to be completed at the end of December, after which we'll be using the month of January to incorporate IT recommendations into the budget. The budget that we have in front of us essentially does not include any IT funding. It is more so geared towards project operational costs, so that we can get out there and start meeting speed and scale numbers and things of that sort. Also, an open item still on CRFP funding. Some things that we're not too sure of is that on the right there you can see the state has district-wide, PPS-wide, statewide rather, metrics that need to be met by certain timelines. And if we, as 25 PPSs, don't meet the state's overall goal, then the state is looking to cut funding for all 25 PPSs regardless of your actual performance. So if we do really well upstate and downstate is bad, and then we fail to meet, upstate and downstate end up getting penalized. So, and of course, the Department of Health can do whatever they want to tomorrow. So, we always know that the DOH may change rules in the middle of the program. And the other reason we want to be flexible is we may wish to reallocate funds but from one project to another, or one budget category to another. On slide 8, we have the waterfall concept, first introduced in early August. What we've got here is the money originating at CMS and flowing to the DOH. We had, at the beginning of April, we had just shy of $2.4 million remaining in our from our implementation planning grants. We add to that our total project valuation of $213.6 million. We end up with a total potential value of just shy of $216 million from the Department of Health. What you'll notice is missing from here is the high performance fund dollars. And so we're not entirely sure, one, how we're going to distribute that, and two, if we'll even get any of that. And so it is not included for the purposes of this budget. And so that $216 breaks out into essentially 6 different budget categories. We have the best haircut you've ever received because it costs $26 million. That represents actually the money that we expect to not earn from failing to meet certain milestones or objectives or speed and scale numbers. This also is how we're going to take into account the potential for the state to dock all the 25 PPSs for not meeting some of the statewide metrics. If that happens, we expect those dollars to come out of essentially this haircut. And so that leaves us with the 5 remaining categories of administration at $20 million, contingency and sustainability at approximately $10 million, project implementation looking good at $78 million, $20 million for incentives, and $61 million for revenue loss. This is the bucket that makes up for how well we do with our projects as the hospitals see decreased volume. This bucket is to make up for that. I'll also note, though, that if we fail to decrease avoidable patient admissions and visits, we won't be giving out any rev loss dollars, and so we'll be evaluating the rev loss as time goes on, because those monies, if we don't realize those decreased admissions and ED visits, those rev loss dollars get freed up to be applied elsewhere. And so that leaves us with an actual available budget of approximately $189.6 million. Oh, math. Just to give a quick background on the $213.6 million, these are our original valuations from our DSRIP application. The state valued each of our project applications subjectively and applied it to our attributed population and applied a PMPM dollar value to it and came up with these dollars. Just a quick piece of background on that. Oh man, this is the best slide. For those of you who can read this, congratulations. But this is the master funds flow table. It actually contains at the top the master operating budget, and below that is the master capital budget. Below that is the balances for the contingency and sustainability funds, and then below that is the operating fund balance and the capital fund balance. And essentially what we'll focus back on the master operating budget. And so we have a starting balance with the revenues representing the potential maximum that we could receive from New York State for that particular check. And then applying the haircut that I'd previously referenced, giving us a projected DSRIP revenue on the following line. Less our expenses of admin, project operating funds, project contingencies, and then there's a brown line that says project's capital outflow, and that actually matches up with the brown line in the master capital budget as we move money from our operating budget to our capital budget. We have our incentive budget and our rev loss budget also on those lines, and so it all comes out. There's the total costs and the net flows. One thing to note is that this is, if you look at the master capital budget in DSRIP year 1, quarter 3, there is an inflow from CRFP. This budget that you have in front of you assumes 100% funding for the $14.3 million that we've asked for the CRFP dollars, and specifically our CRFP request is entirely related to IT. And so this budget operates under the assumption that we get all our money. And so to the extent that we don't, obviously that is something that will have to be revisited. About our revenue. So payments are made by the Department of Health to CareCompass Network every January and July through 2020. And actually that statement reminds me to go back actually to page 11. As you look at this budget, it actually goes out to what we're calling DSRIP year 6, quarter 2. Knowing the DSRIP is only a 5-year program, we're just going to call it year 6. The reason it goes out to this extent is to reflect the fact that our last check is not received until 4 months after DSRIP is over. And so we needed to, one, account for those dollars and the expenditure of those dollars. And so our actual budget goes out to DSRIP year 6, quarter 2. Okay, back to revenue. Again, as I said earlier, statewide performance can impact available dollars. We're not including high performance fund, and the CRFP is assumed to be received in 100%, but it is subject to decisions that were expected to be made in October, but have not yet been made. And we don't know when either, because they haven't told us that. The revenue methodology, as you know, it's broken out in pay for reporting and pay for performance. And so this simply just shows the breakdown over the course of the years. Pay for reporting along the top line, representing just shy of $120 million over the DSRIP program, and then pay for performance representing just under $94 million. And as you can see, the big shift happens in district year 3 as the pay for performance money goes from $5.4 million to $26 million. Another way to look at it, this is the breakdown as it relates to the different project domains. As you can see, domain 1, which is entirely pay for reporting, simply drops 20% a year until year 5, in which it is worth nothing. Oddly enough, domain 1 is actually where speed and scale payments are housed. They're not a pay for performance measure. They are in the sense that if you don't get it, then if you don't achieve your speed and scale, then you don't get that money. But speed and scale is actually contained in that first line of pay for reporting. And that is why there is no speed and scale for year 5, because as you can see in the box, it says it's 0%. Going through our budget categories, we have administrative. You've got salaries and fringes, rent, supplies, legal services, infrastructure purchase services, other central consulting. Our RPUs each have a budget of $25,000 per quarter per RPU. Also some dollars in there for insurance, training, mileage, travel, and other miscellaneous expenses. As well as underneath that, you can see several key assumptions that were made in determining all of these numbers. These numbers reflecting the thought process as of October of 2015. We've not yet anticipated any major changes to this budget since then, though. Due to the fact that salaries and fringes represents $11.3 million, we do provide a detailed list of essentially what all that entails. And so you've got all the different positions at CareCompass Network, and as you can see, several of those positions are full. We do have several jobs available, so please check out our website, and if you know someone looking for a job, we're also looking. And so now we get to the exciting part, or we're almost there anyway. So this is the project budgets in 2 different ways of looking at it. The top one includes the domain 1 projects and then the domains 2 through 4. And so these project budgets are at the top do not have CRFP dollars in those numbers. The CRFP dollars are incorporated into the bottom section for domains 2 through 4 with CRFP funding. And so when you actually add in CRFP funding, our actual project budget becomes $92.5 million from the original 78. The project reconciliation page was very helpful for us. For each of the projects, as you can see listed on the left, we went through and we tried to identify monies that we definitely knew were going out the door to the different providers within the PPS. And we knew that there were some expenditures that would likely go to vendors. And so, as you can see, we've already identified $32.9 million as going to identified partners. This is for essentially all the speed and scale is really what this number represents. There's some dollars there for vendors. Columns A and B adding up to the following column C. We have an IT budget in column D, representing some of the different IT initiatives that we're thinking about. Again, none of these are set in stone. Most of these are made up on some recommendations from some of the projects teams. They'll be finalized more so after the completion of the Weiser Mazars engagement. This gets us to a subtotal in column E, on top of which we added 15%, because one of the things that we don't know right now is what's going to happen in the future. And so to the extent that these projects will need additional dollars for things that happen to come up as the state changes what it is they want us to do, we've incorporated a 15% contingency into each project. And that project contingency totaling $12 million over the course of the 5 years. And so that will be used for items as they come up that were previously unplanned. And that gives us to a total in column G, adding up to the $92.5 million in the yellow box. And then if you wanted to break out the CRFP dollars by project, you could do that. in the section to the right as it breaks out those total, the column G bucket into CRFP and not CRFP dollars. And now the moment you've all been waiting for, truly, is all the information about the projects that we've signed up for, and some of the payment methodologies that we're looking to utilize. And so I'll walk you through this format, as we've used the same format for this page and the following 11 pages. So at the top, you essentially have the title of the project, and then below that is a description of the very short description of the project. To the right of which you'll see the CCN project lead as well as our external project lead. And then going down, you've got all of these different line items that are things we're looking to pay for to essentially achieve these projects, and all the different line items across as you see those. So let's take, I'll use PPS consents as the example because that's the one I always use. And so going across, we're going to walk through PPS consents. And so that's an operating expense. And it says here that we're going to pay per consent at $5. We're going to do 189,000 of them. And so that's going to cost $945,000. And so we're going to pay that to our partner organizations. And so there's an allocation basis. So when I wrote this up, this budget up, I had to come up with a way to try to figure out where we might want to start contracting.
Good afternoon, this is Sarah. Can I help you?
Hi, Sarah. You're on speakerphone. Could you please mute your WebEx, please?
I'm sorry.
Thank you. Sarah, this is the Care Compass Network PPS. We can hear you.
Okay. This rings to the front office. Were you trying to reach the front office?
No. Stephanie, help me out here.
Sarah, just hang up.
Okay. Alrighty.
Thanks.
Thank you.
Oh. Sarah, also known as call-in user 19. Oh, dear. And so we use the Salient system, which is the Medicaid claims-based system. It's built off of the eMedNY data. And so what we did was we went in there and we said, give us all the providers in our PPS in descending order in terms of the number of unique Medicaid clients they served in calendar year 2014. And so based on that, I took the top 100 organizations, and I said, all right, these might be people who we could get to do consents for us. And so there are advantages to this methodology and there are disadvantages to this methodology. The advantage is that it gives us a place to start. The disadvantage is that if you don't bill Medicare or Medicaid, you're not in there. And so that's when we look to our friends at the local level, at the RPU level, to help us identify additional partner organizations that we'll want to contract with. I think the popular example I like to use is a food bank. They don't bill Medicaid, but we do need them for certain things. And so at the RPU level, they're aware of those different services, and they can help us point us in that direction so that we can include folks who wouldn't show up when we look at Salient data. And so that's essentially the allocation basis. And then our timing basis is because it's not only how much we're spending and who we're going to give it to, but when are we going to spend it? Because it's very important that we don't run out of money. And so the timing basis column went in there, and so for this one I copied the scale and speed of the 2DI project to figure it out, because there is no actual speed and scale for the integrated delivery system. And so then we come upon a description column, essentially a bit more information to add to just the concept of PPS consents. And so this is really for consents to share the performance data with the PPS. There is an open question there that I had written. It says, can we have just one that includes the RIO consent? And we're not going to do that. We're just going to have two consents. Right? Right, Rebecca? Well, all right. Well, we budgeted for two. We budgeted for two. And so then where did we come up with some of this information? Well, so $189,000 is actually based on our attributed Medicaid lives plus the number of uninsured that the state gave us, which was an estimation, and that was $189,000. So I said, well, let's assume the most possible, as we like to budget very conservatively, because it's always easy to take money back, and it's never that easy to give them extra money. So, and then on the right, you can see who we worked with on this particular line item, any barriers or open items, and then a specific person for contact. Where it says ETA done, that just means that we've figured out all of the other information on that particular line. It doesn't mean that we've actually accomplished anything. And so that is essentially one line item, the PPS consents. I'll actually move down for a comparison line, the EHRs. And so as you look at an EHR, that comes out of the capital budget. The payment is per provider. There's a cost factor of $49,500. This was based on an AHRQ study that said $49,500 is the cost to implement an EHR for one provider as well as maintenance for 1 year. It's not necessarily true that this is we will not say, well, how many providers do you have in your office? All right, times $49,500, here's some money. Some of these items, especially actually all of the EHR, the Rio connections, and the PCMHs, all have a line item in their description that says estimated will vary by provider. We use the $49,500 as an estimate for how many dollars on average it could cost to do that. We don't have a quantity yet, however, as that is one of the things that we expect to get from our engagement with the Weiser Mazars folks. And so that's why you see those items are red and saying TBD. And so the ETA on that line is 12/31 because that is the end of December, which is when we're expecting Weiser Mazars to complete their PPS IT assessment. And so all of the IT items are actually going to be red in this particular iteration, just because none of the IT budget, which is $42.9 million, has been set in stone. And so essentially that's how you read these payment line items, the operating and then the capital. You add up all the stuff in the total cost and you get a subtotal. We add a project contingency, you get a total cost. There's $23.3 million unallocated in this budget. It is to be applied to the EHR, the Rio connections, the PCMHs, and then some kind of care coordination or population health software for the PPS. Below this, you can see if there is scale and speed for a project, what is it? And then as well, the project metrics, which will determine, these are the metrics that the state has chosen to essentially grade us on for when it comes to pay-for-performance reporting, pay-for-performance. And so our performance on all of these measures is what's going to determine up to $93 million of our funding, as represented in an earlier slide. And so for the 2AI project, you've got all of these different metrics, the avoidable ED visits, avoidable readmissions, length of relationship with a primary care provider, some caps, some HCAHPS measures, access to care, Medicaid spending, all kinds of different metrics that the state has chosen from their, and this information was obtained from the DSRIP specification and reporting manual. That's another lovely document. It's like 80 pages, I think, now that they revised it. So for 2AI, we are looking to have some data analytics. We're looking to pay for providers to get PPS consents, Rio consents, and then we're looking to have EHRs, Rio connections, and PCMH certifications put in. At the very minimal, we need to do that for our safety net providers, as outlined by the state. And so really this is one project, and so I'll go through the next 10 projects a little bit faster as we're now familiar with the layout. But I will pause always to ask for questions on each of the individual projects. So are there any questions about 2AI? Hearing none, I will move on. Oh yeah, check my chat. Nope. All righty. 2B4, care transitions. And so I'll just throw this out right now. This is one of the projects where we're looking to add some line items. At the time that we made the project, we had the hospital side of the care transition, the discharge plan. We had the home visit within 7 days. And then we found out we missed out on the phone calls that are required for by days 14, 21, and 30. So that's one item that will be added into this budget for what we're expecting to be the February revision. Also in this budget is an IT item for telemedicine. It says Care Trends. That is a vendor that was identified by the project team, and so it's listed there as the preferred provider. Again, none of it's set in stone because it is IT. However, the cost factor is from a proposal received by the vendor, and so we were able to slot that dollar amount in at the very least. So looking to add follow-up phone calls to this project's budget. Are there any questions about 2B4 care transition? Wonderful. 2B7, Interact protocols in skilled nursing facilities. So here we're looking to pay for training at the SNFs, and then we're looking to pay for the successfully documented implementation of Interact protocols. That used to be called avoided ED visits until legal saw it. And so this is essentially the speed and scale for this project. What we're going to do is identify certain protocols within Interact that would likely result in the prevention of an ED visit and pay a set dollar amount for those interventions. And so based on the speed and scale for this project, we're going to do 2,800 of them. So that's $772,000. And I see someone from the nursing home just giving me a look and smiling as we've discussed this in the past. And so I'll bring up to this point that if you look at this and you say $772,000, and we have 23 nursing homes, what's that, like $22,000 a nursing home? And then it's over 5 years, and then there's 12 months in a year. What's a nursing home going to do with $500 a month? Not a whole lot. And so to that extent, and because we know that the nursing homes are necessary for our success, this essentially is the expenditure that we've laid out for the project, but there is the expectation that in the future, CCN will be creating what we're going to be calling an innovations pool of dollars. And so we're going to try to find ways to get our skilled nursing facilities some dollars, not necessarily through this project, but through some other mechanism using those dollars. You'll notice that the innovations dollars are referenced nowhere in this budget because at the time that this budget was created, we really didn't have a good handle around, one, where are the innovation dollars going to come from, where are they going to go. And so that's something that's still in progress. But for the skilled nursing facilities around the table, we know $500 a month doesn't do a whole lot. And so we know we need to do something else. In addition, we are looking to implement Interact into EHRs that will have to be put in. And so we have these two line items. The cost factor here is not necessarily as important as it was used to get to the total cost. So we have $2.7 million for IT for 2B7. We have a question on the chat. In the FOF budgets, where are costs for care coordinators embedded that are not project specific? Pam, that is a wonderful question, and you ask this every time I think we go over this. It's not a line item in any project, so Pam, maybe I'll go back to that earlier innovations dollars, or as we come up with, there is care coordination built into some of these projects. There are, I think, three or four projects that do have a line item for care coordination. But you're right. You know, if it's not listed right in the project, there's not really a line for care coordination anywhere. You're welcome. I like that. That's neat. So, I mean, we're going to see what we can do about that because we know it's yet another area that needs to be addressed. But at the time that we put the budget together, we just weren't sure where would it go. So we're working on that. Any questions on 2B7? Great. 2CI, Community Navigators. Before I get into this, let me just say it's going to change a lot. I'm already blinking? I'm not. Nope. Don't do that to me.
The red will blink for the recording.
Yeah. So 2CI, Community Navigators, so we're looking at paying for, I mean, some of this is still the same, but the dollar amounts are definitely changing and some of the frequencies are as well. So looking at navigation services, we're redefining this, we're calling it a Type 2 navigation. It is the Type 2 is one way we're going to do navigation. The other one is currently labeled 211 calls for speed and scale processed by CHAS. We're going to recall that Type 1 navigation. And so we've also got the implementation of a community care resource guide, yearly CHA forums, some incentives for CHA training, as well as some navigator marketing over the course of 5 years, and then some IT dollars in there to assist the 211s as their current IT infrastructure does not allow for tracking of any types of the data that is necessary for us that we need to report on to New York State. And so we are looking at moving some of these dollars around as well as adding some dollars overall, but we're still working that out with the team. But we do hope to get some of that in there for the February revision. I hope there aren't a lot of questions on 2CI. Sharon?
No, Bob, thank you.
Oh, you'll reserve comment for later, I'm sure.
Okay.
Sharon's on the 2CI team. Moving on to the PAM survey. All right, so on the PAM survey, this is one of the most straightforward ones we have. We've got some dollars set aside for Insignia Consulting in case we don't know how to deliver a survey. PAM's, what's that?
Got another question?
I have another question. Ooh. Well, Pam, oh, yeah, well, it's on the, I think it should show up on the video too, but yeah, I will say. So Pam asked, how can CCN contract for 2CI deliverables if the dollars aren't going to be revised until February 2016? So the one thing that you can change without having to go through an actual budget revision is you can move dollars around, because the amount that is spent in a quarter has been approved, and the timing of that has been approved. But so if you want to move dollars in the same quarter, and you want to move them from paying for one thing to another, we can do that without any approval. The actual approval needs to happen when you want to add dollars to a project. But if you wanted to just move dollars around and keep your total budget the same, that doesn't require an approval. But we do know that we want to add money because we've identified that the Type 2 navigation services are going to require some additional funding.
How about that question? Because I think if I'm reading Pam's question correctly, what you told us earlier is that any budget changes would get presented to at the February meeting. Not go to the state.
No, it just goes to our board.
Correct. That's to our board.
Yeah.
So with Pam's question, can you do that negotiation with entities willing to take on this work before the board approves the budget change for this project in February?
Well, for one, the contract negotiations are not we end up saying that a navigation, type 2 navigation service is X dollars and type 1 is Y, that's not up for...
That's totally understandable. However,
Right.
nobody in their right mind is going to contract for a dollar amount that is yet to be determined on something that the current dollar amount is not appropriate, will not cover the cost of actually completing the service. That makes sense. Yes, I understand.
So then it's that's contracting for those
That would present a huge problem for the project overall, speed and scale, March 31st.
Now, so to that extent, the penalty for not reaching speed and scale on any individual project this year is approximately, in any particular payment quarter, is about $60,000. Next year, it's like triple that. So to the extent that, as you know, we've missed several speed and scale numbers from our Q2 filing, as we filed a 0 for everything. You know, to the extent that it's not that it's okay, it's just that it doesn't hurt as badly, you know, essentially. And there is a haircut built in there for a reason. Based on how I think we performed, so our next check has a maximum value of about $6.6 million, of which is budgeted a haircut of $900,000. Based on some estimates that I've run, I think our actual loss will only be like $300,000, maybe $400,000, and so we're already looking at doing better than we budgeted. And so, you know, essentially that not meeting speed and scale is kind of already budgeted. And since the counter resets in April, you wouldn't have any catch-up to do because every project starts at 0 in April. So to the extent that I don't know as if it's as bad as it sounds or could be, just because it's a light penalty for not meeting speed and scale, and the counter resets in April anyway. But there are further discussions to be had on that internally on what we want to do with that. February, Pam. Early February for the target date for revised reimbursement. You're welcome. 2DI. PAM surveys, 221,000 of them across the 4 years. Train the Trainer was $12,000. That was for Insignia to come down and deliver actually 2 3-hour sessions. Training for additional folks across the PPS to get trained in how to deliver the surveys. We're looking to have 318 additional people learn how to do the surveys at 2 hours at $65 an hour. Those folks who came to the Insignia training on September 29th at Care Compass Network, there is some money in this budget for your organizations. For those of you who sent folks there, we will be paying for that upon signing off on the contract for this project. PAM tablets being a capital item. And if my Lord's people are still here, so I'm just going to reiterate that that I know the description says estimated 16 gigabyte Wi-Fi Apple iPad Air 2. I know there are some organizations that are not necessarily what you would call Mac friendly. So I just want to reiterate that this is just an example and where I came up with $600. Not that we will be utilizing Apple iPad Air 2s, but just that it's a cost for a tablet. Then we have $421,000 for the PAM license. This is our contract with Insignia. We've already signed off on that. And then as well some dollars for PAM interfaces for CBOs as we look to possibly integrate the PAM survey into any electronic documentation that's available at your organization. Any questions on 2DI? Loving it. 3AI, integration of behavioral health and primary care. And so going along this project, we've got the integration and co-location of behavioral health into an existing Article 28 site. You look at the cost factor, it says $50,000 across 40 sites, so it's $2 million. Highlights for these line items are that these are estimates and will vary by location. As well, it also works both ways. This also includes the integration of primary care into behavioral health. In that instance, it would be integrating primary care into an Article 31. And then there is the integration and co-location of one of those services into a non-28 or 31, knowing that there's some additional cost involved with those sites. We've got a line item for $200,000, but only at 5 sites. And so then we have our speed and scale, which is the behavioral health screenings or preventive care screenings, depending on what integration, what it is that you integrated. Looking to complete 216,000 of those across the next 5 years. And then it also included in this is 1/3 of the estimated cost for a program called Behavioral Health Works. This is the preferred vendor for all of the behavioral health teams, and so as it was identified, I've split the cost 3 ways for across the 3 behavioral health projects. And so 1.15 million is just 1/3. Hello. Okay. Are there any questions on 3AI? Yes? No?
To be able to read it.
Beg your pardon? I think someone said they had trouble reading it, but for that I would reference them to their PDF where they can zoom in. Question in the back?
Yes, so the tablets are going to be effective in use when?
Beg your pardon?
The tablets, behavior work.
Oh,
When?
and so behavioral works is an IT item, and so therefore it's actually not a guarantee that that's what we'll be going with. It's there just because it is the preferred software vendor for the behavioral health teams. The IT assessment is going to be completed at the end of this month, and so the IT items will make their way into the budget for, we're hoping, the February revision. And, you know, at that time, once we've got a better handle on the IT softwares that we'll be using, I'd be able to better answer that question.
And the tools.
Yeah, the tools and the software.
One model.
Yeah.
It's budgeted in, but
For an IT solution.
all IT systems.
Yeah, there's a hold for IT dollars, really, if you want to generalize it.
What? Oh, like
So-
she doesn't. Oh, okay.
Can you please put your phones on mute? We're hearing talking. Thank you.
Any additional questions on 3AI? Hearing none, I shall continue. 3AI, Crisis Stabilization. This is another project that is in the process of having several line items added in. So what you have here is the creation of additional mobile crisis units across the PPS. The thinking in October, or rather really September, was the creation of 3 additional units, 1 for each RPU. The only one that currently has one in existence is the South. There is the potential to piggyback on some nearby mobile units in some of our more rural areas, but that's currently still being explored. Care coordination, there's a line item for care coordination right there. For the target population, $234 per month. It's a 3 months of care coordination following a mobile crisis unit episode of care. The $234 is representative of medium level acuity for non-HARP upstate Medicaid members for the health home. So that's the basis for the somewhat seemingly random number placed there.
Can I clarify one
Sure.
So, we're gonna have teams that go out and they're crisis.
Yep.
Once they act and provide service,
Yep.
then there would be provision for follow or triaging to the medical home.
No. So that's the medical. The health home was just the reference that we used for the dollars. The actual care coordination will be done by CBOs essentially. Okay. All right. And so then there are follow-up visits for the mobile crisis unit episode of care. Some of the additional things we're looking to add into this program, or this project, is the inclusion of respite services across the PPS. And as you can see, there is another line item for BH Works, this representing, of course, again, 1/3 of the BH Works expense, but essentially actually being just a placeholder for IT dollars in general. Are there any questions on 3A II? Well, that's splendid. 3BI, cardiovascular disease management. Where's Pam Guth with her questions now? This is Pam's project, and Debbie. And so 3BI, cardiovascular disease management. The approach that we're going to be taking with this project essentially is the CDSMP training model, if you will, where folks across the PPS receive master CDSMP training. Then they go out and train peer leaders at different provider organizations or CBOs. And then those peer leaders train the actual Medicaid beneficiaries. It's an actual program, and the beneficiaries can graduate from it. Pam Guth can tell you all about it. Julie Ramage is actually a trained peer leader here at Care Compass Network, so we'll be putting her to work. Some line item here for care coordination for self-managed patients with documented goals in the care plan. So some dollars set in there for maintaining an up-to-date cardiovascular screening panel consisting of hypertension, lipids, A1Cs, and the 5 A's of tobacco cessation. Possibly looking at purchasing some home blood pressure cuffs for our participating patients. Some EHR referral programming and provider alert setups represent the IT dollars that we've conceptualized at this point. Are there any questions on 3BI? Oh, no. It's Pam Guth. Oh, she smiled. Well, you know, Pam, when you smile, the whole world smiles at you. Yes.
Question, because after thinking about this, is the volume of folks for the screening is what I can't see of it.
Oh, wrong page for me. I have 14,393.
Pam and I talked about this, so that's how many patients I believe currently we believe have cardiovascular disease. So would we not want to screen perhaps the larger component of the population? Right, the unknown. I think we just need to look at that.
Sure. Oh.
Yeah, I think those are the current knowns.
Peer research. Oh, we just learned that Julie Ramage is out because she did not do a recertification this year. Thanks for the info, Pam.
Good job, Pam.
All right, so I've made a note to check that out, investigate that with the two of you. Any additional questions on 3BI? Wonderful. 3GI, palliative care treatment in PCMH locations. So we're looking at training for palliative care staff and then having them do home visits and follow-up phone calls, and providers for fully completing their EMOS and training primary care staff. We have our speed and scale item here of participating patients, essentially patients who have a visit in a PCMH location where they receive a palliative care treatment. The IT items involved in this one is the EMOS integration into the PCMH EHR, as well as the palliative care pathway integration into that EHR. Also a line item for, I think I skipped one, yes, the partial FTE startup payment to assist the hospice providers with bringing on new staff. It's once per organization, only received upon actual hiring of a new employee. And so that's it on 3GI.
I have a question.
Yes.
I guess my question is in regards to paying hospice organizations.
We're not. There are other organizations involved in this project as well, but don't ask me who they are because I cannot recall it. But it's not just hospice.
Right, the people in outpatient palliative medicine
Yep.
programs, the nursing homes, they participate in this work with members, so this is trying to right, here in those locations.
But yeah, it's not just hospice organizations. So that part I can't say.
Even though it says that.
Palliative care staff can exist in more than, yep. Make sure, okay. Let's see, 3GI, going once, going twice, sold. 4AIII, strengthening the mental health and substance abuse infrastructure. So based on this project's implementation plan, there were a couple of line items, procuring evidence-based screening tools and providing evidence-based targeted intervention services. The thought from the team was that these are essentially concepts and tools that are already included in BHWorks. And so that's why it just says included in BHWorks. However, they are in here because we wanted to know that those had been considered. Yes?
Already in place for payment.
So the SBIRT is one of the approved behavioral health screening tools. Okay. I do recall that. Okay. I think, right, Wayne? Wayne's. I think so. It's so common. I would think that. Yeah, I think it is. So. Did I answer your question?
Yeah, no, I mean, I'm just envisioning where these tablets are going. How many we're going to have.
You like tablets?
I do. We've always worked with behavior work.
Oh, okay.
At the hospital. They do a great job.
And then so the training for behavioral health works, and then here lies in the other third for the cost of behavioral health works. Make sure we got, okay, good. So fairly straightforward on 4AIII. Any questions? 1, 2, 3, gone. 4B2, COPD disease management. And so we're looking at some screening protocols, maintaining up-to-date PFT screenings and results. Oh, we do have a question? Oh. SBIRT and PHQ-9 were the original choices, yet Department of Health since revised. SBIRT is a framework with many mental health and substance abuse screenings embedded. Pam Guth. All right, back to 4B2. Let's see, care coordination for our target population, making sure that we're up to date on our flu, pneumonia, and pertussis immunizations, $10 for smoking cessation enrollment, and $1 million for IT, which is broadly defined as some kind of patient reminder as the PFT results come into an EHR, it does something. This project does not have a speed and scale, nor did it have a prescribed implementation plan by the state. So essentially, Pam and Debbie had to come up with their own. And so to the extent that some of these, it's been a while. I can't even remember where I came up with these numbers. I think I mimicked some of the.
Yeah, we mirrored some of the cardiovascular.
Yeah, I think that's what. I'm fairly certain that's what. Yeah. And COPD, cardiovascular, fairly close, but not exactly the same. Yeah.
Pam's probably
What up, Pam? Oh, it is Pam. Yes, and these are aligned with the New York State Prevention Agenda Framework. And so that's 4B2. So that, along with 4A III are our two Domain 4 projects focusing on the prevention agenda. Are there any questions on 4B2? Man, this is great. So Domain 1 projects, where we have workforce, cultural competency, IT, financial sustainability, all different conglomeration of expenses. So we've got cultural competency education, VVP education, financial consulting, IT needs assessment, and then I think the rest of it is all workforce specific. Health Workforce New York engagements, a salary survey that we need to conduct, a workforce application for conducting e-learning, creation of e-learning modules, and then the redeployment, retraining, and recruiting of resources throughout the PPS. It was Pam Guth. We don't need to read that. No. Includes, see, we can hear Pam laugh, but she won't say anything. Includes CDSMP resources paid from the 3BI budget. Pam, to what are you referencing this comment? What includes CDSMP resources? Oh, okay, thank you. You could have just said it. You're not on mute.
Yes, I am.
No,
okay.
you're not.
No, you're not.
No, you're not.
Oh, we try to have fun talking about a budget, but we do our best. So that's Domain 1 projects. Oh, yeah, there we go. Any questions on the Domain 1 items? Spectacular. So rev loss. We're not really sure how we're gonna validate the actual loss of revenue for organizations yet. But what this budget is loosely based on is an estimation that in years 2, 3, 4, and 5, avoidable visits will decrease by 6.25%, because when you multiply that by 4, it gets to 25. And so we pay in the second DSRIP quarter for the previous DSRIP year. And so right now we've got these placeholders in here, but as we work on developing a methodology and whatever the state may want to throw into this equation, we'll be developing that. But it's on our radar, but we've got some placeholders in the budget for that expense. I wanted to also throw in there the math model behind how some of these numbers were derived. These came from our friends at H5 Consulting. They worked on this at least before my time, but I've included them in here for reference. Moving on to the incentive budget, we have two categories. High performing and then the participation incentives, which we're also calling readiness bonuses. So for those of you who have EHRs or are already connected to the RIO or have PCMH certification, we're looking to recognize the work that you've put in at your organization and so provide you with a readiness bonus. The methodology behind the readiness bonus is one of the new things that we'll be looking to include in the February budget revision. Thank you. And then also and so that's $4 million, and then we have $16 million set aside for high-performing providers. Again, the methodology on this piece not having yet been developed, but hopefully something that we're going to be incorporating into the February budget revision. Robin.
For the, is there going to be some kind of structure for CEOs that have subcontractors to build their contract? Or is this only going to be?
Well, I kind of wondered why you didn't talk. Unmute and talk.
Oh, no, we would work that into a subcontract just because if you weren't going to directly contract with CCN, likely to get around the 5% safety net cap is what you're referring to. No, we would want to make sure that those incentive dollars were distributed. So you still got those, despite not being able to. Yes.
I think that's something like that was reminded to the board the other day, though, by council. There are certain things that the organizations will have the contracts, you won't.
Right.
CPS won't, and, I think we were there, right, at the board meeting, that was very clear from council that there has to be that arm's length, and the ability of each individual organization still is mandated by their boards and that of what they will be contracting for and that. So I hesitate to just have that out there, that it's an automatic, it's going to be, that it'll be part of the contract with PCS. Because I think it's going to have to be the subcontract between safety net providers and the CBOs that when there's that pass-through in addition.
Well, really what I'm just trying to say is that just because you're subcontracting doesn't mean you won't get the dollars. That's really all I was trying to say. Right. So if it came out any other way, my apologies, but that's all I meant to say.
I just wanted to be clear that it's not going to be a direct link back into the there is that collaboration.
I mean, there will be some direct non-safety net contracting, but again, and not so much that we can, we want to make sure that we don't go over our 5%. But there will be a mechanism, no matter how you're contracting with us, whether either directly or subcontracting through a safety net provider, you'll get your incentive dollars. Because that's not fair. So let's see. So that's the incentives. And so earlier, let me just make sure. Okay. So earlier, when I was talking about that allocation methodology, I said I was allocating dollars to organizations based on some salient data to try to get an idea of where to contract with and where some dollars might go. Upon completing that exercise, we found out that we're definitely going to have definitely going to go over that 5% safety net limit, if you will. And so this really just says that, yep, we definitely know that we can't direct contract with all our non-safety nets, and we're going to need to come up with a solution. That solution is, as of yet, unknown. We are still working with legal counsel on that. But at the moment, it's not too much of a problem, just because in the earlier years of DSRIP, there is a lower spend. And so it's in the later years where we really run that risk. So we've got some time, but not a ton of time, to finalize that approach. The proposed funds flow budget, this is essentially how the board saw it. You saw all those wonderful tables, and while the board did see this packet as well, this is really what they this is what they saw and voted on and approved. It's just another way of looking at it's really combining different elements like the waterfall, the CRFP funding, and some of the other items that you've already seen throughout this. Some footnotes to this is just that, that really things that we've already talked about, but I included it here because it was something that was presented to the board, and so we want you to know exactly what the CCN board did see and approve. So we talked about why there's a run out to DSRIP year 6 Q2, explain the contingency funds. You can ignore note 3 because this is the detailed methodology package. We talked about the project contingencies and then what we'll do if CRFP comes in less. The budget authorization matrix was also approved by the board at the October meeting. This shows the dollar level authorizations that are required to alter the budget in terms of total dollars. And so, as I had previously said, if you want to move your approved dollars within a project around, nothing wrong with that. If you want to add some dollars to the project, well, depending on how much you need to add, that tells us where that approval needs to go, whether that be the Finance Committee or the Board of Directors. And so on the following page are several notes to this budget authorization matrix, but it is here, and so we do have a method by which we can change our budget. So the CCN board essentially approved our funds flow budget for the 5 years plus 2 quarters and the flexible budget methodology to amend that. Remaining items include communicating with providers and partners. That gets done today. Oh, joy. And then to continue work on our contracting process, completing our pending items on the following page, developing a mechanism by which we can report actual to approved budget, and then actually flexing the budget and utilizing the authorization matrix. Actually already completed is the development of a tracking mechanism of budget changes. In each budget Excel packet, there is a tab that says essentially the changes that you'd like to make going from this budget iteration to the next iteration. And so in each packet you see here's how the budget started, and then here we're going to make these changes, and then in the following iteration you see how those changes have taken effect. The pending items include such things as the approach to the safety net funnel, the methodology for incentive payments, rev loss, the allocation of the IT funds, CRFP, all things that we've really already discussed. And then the final slide is a projected spend calendar of when we think we're going to be spending. So this is the money that we've anticipated is already going to go to providers within the PPS. And so this is essentially the anticipated timeline for that spend, to the extent that we thought back in really late September as we were preparing it for the October board review. That's it. Ooh. Is there an appeal process when there is a difference of opinion? So yes, you are referring to our dispute resolution process, and so it is part of our policy that we have on the SharePoint. We have a disbursements policy, and in there is a section about dispute resolution. So you're welcome, Kurt. Let me just make sure there wasn't a question above that. Nope. Okay.
I have a question.
Sharon.
Not necessarily perhaps related to the budget specifically, but with the contracting process, as you are working with whomever might work on any particular project, will you be contracting solely on sort of what they project they can do, or will you be looking at it in any sort of a timing cycle? Like, would you want to have a contract that falls in each one of the 5-year periods, or would it be a full piece over a long period?
Yeah, the contracting is not for the full 5 years when you start.
Right.
It's for,
I believe it's one.
yeah.
One, and then that one is a running one, or is it, again, in alignment with something?
It won't be a running one. It would likely be updated annually because the numbers that we're going to be contracting with you to do will be increasing.
Right, I'm not saying that. When I'm saying a running contract, I'm saying if you contract with entity A in March, does that go to March of the following year?
Yes.
For them, even though, let's say the cycle, is April through May, or April through March for the CCN overall, for district overall. And if project, or if agency B contracts A, then they're a running cycle for that 1 year.
Till March.
And it's actually,
Just till March.
That would be my guess.
It's going to.
I'm not 100% sure on that.
I'm not either, but I would say that's my guess.
But just to be clear,
I think it is.
Based on what market.
the contract, there's
Yeah, it's because
several different ways that we're looking at it. I mean, the big 25-page contract, that is something that lasts through the full 5 years. And then there's
The Appendix C.
Right. So each Appendix C stands on its own for each project. They can be updated
which would fall in at the end of the district year for the following for the next district year.
Right.
Right. Because that's when our
through the district year.
Yeah.
I'm not going to scratch that off the top of my head. But yeah, so you can, and then if you decide as you're going that you contracted for one project, a service limited contract within that project, and one reason or another it doesn't work out, that the way that you thought something was going to work, it doesn't. Both Care Compass Network and the organizations mutually
Are there any other questions? Thank you, Bob.
My pleasure.
We'll adjourn the meeting. Thank you, everybody. Have a safe trip home.